a crisp and practical presentation on airway guidelines and rescue strategies. Our final speaker for this session is Dr. Anil Kumar MR, Professor, JSS Medical College, Mysore, who will be taking us through the role of ultrasound in airway management, a tool that is rapidly becoming indispensable in modern anesthesia practice. Let's welcome Dr. Anil, sir.
Thank you for the kind introduction. And I bring greetings from my institute, JSS Academy of Higher Education and Research. I immensely thank organizers for having me here. And that too, I am very fortunate to stand in front of luminaries in the field of three musketeers sitting there in the field of anesthesia. One or the other way, they have guided, they have mentored in the journey of anesthesia. Thank you, sir. What is this picture? Just few minutes back, I had happened to put this picture with Dr. Ramkumar's advice or the triggering. What is this picture says? This is a light at the end of the tunnel. So the topic is what the light at the end of the ultrasound is going to help us in the airway management. I have no disclosures, no conflict of interest, and informed consent is taken from all the patients whose images from my institute I am presenting here. We will learn why ultrasound is used in airway, the basics of knobology, utility of ultrasound in airway management, and images to remember. Why ultrasound in airway? Because we're all familiar using ultrasound for a different purpose in operating theaters, maybe for a nerve blocks or the FAST. It is non-invasive, safe modality, portable imaging compared to MRI and CT scan, which gives very static images, and ultrasound helps in getting a dynamic images, dynamic assessment, and a real-time image. But it also has got a limitation of inter-operator variability. Everyone may not interpret the image in the similar way, and there are lack of evidence for validating certain cutoff values when we use it as a diagnostic mode as a difficult airway management. Certain basics of ultrasound, as you use your mobile, the first is always identify where is the switch on button in your ultrasound. Choose the most effective probe. Here in the ultrasound of airway, it is always the high frequency linear probe. Look into preset. The commonly used preset for airway ultrasound is either thyroid, musculoskeletal preset, or even you can take small body parts. The depth adjustment, usually it will be 3 to 5 centimeters. The gain, it should not be too dark, too light. Strike a balance between those two, which allow us to look at the image very clearly. Coming to the modes, particularly in the lung ultrasound, when we use it as a tool for identifying a proper placement of endotracheal tube, we use M mode, and to rule out vascular anomalies, we'll use Doppler. The patient position, usually either the patient can be in a sitting posture or in a supine with the head in neutral or extended position. The certain maneuvers we may ask the patient to do, ask the patient to make a sound E, or sometimes ask them to stop breathing so that it will allow us to evaluate the dynamism of an airway. Certain ultrasound language which we need to be aware is cartilage always look hypoechoic, that is seen as an R in there. Air looks jet black, anechoic. The bone always looks intense white, and it also casts a shadowing. That means we cannot see anything below a bone when you are looking at a bone. There is an air mucosal interface. That is when air goes, because of a difference in acoustic impedance between the mucosal tissue and the air, we get a reverberation artifacts. And always these reverberation artifacts look like a comet tail appearance. Then its utility in airway management. It is used in assessment of airway difficulty, as either difficulty in laryngoscopy or intubation. It allows us to provide a safe and effective airway anesthesia, helps in selection of proper size of endotracheal tube, the depth of endotracheal tube, confirmation and ruling out esophageal intubation. It also helps in intraoperative diagnosis of catastrophes like pneumothorax, bronchial intubation, or pulmonary edema. It also helps in identifying a surgical airway, the proper level of cricothyroid membrane and the tracheal rings, dynamic assessment of the vocal cord movements to predict the occurrence of post-operative stridor, also helps in confirming the fasting state by looking into the gastric volume. These are certain areas where the must areas whenever you're doing ultrasound of the trachea or the airway. One is the suprahyoid, thyroid placement, thyroid, cricothyroid placement, and suprasternal. If you're able to see and scan these particular 5 areas, most of the time, 99% of the airway ultrasound is done. Coming to suprahyoid view, when I place my probe in a sagittal, mid-sagittal using the low-frequency probe, this is what the image I get. If I want to interpret this image, the uppermost part where the probe marker is kept at cephalad, this is a mandible, this is the hyoid bone. The 2 muscles traversing between these 2 are mylohyoid and genohyoid muscle. The distance between 2 bony structures is hyomental distance. The vertical distance is actually the thickness of the tongue. You can see a bright line there, which is actually an air mucosal interface between the tongue and the soft palate. Any hyomental distance, this is an air mucosal interface. Hyomental distance, anything less than 5.29 centimeters is supposed to be considered difficult airway, difficult laryngoscopy. More the tongue thickness, more than 6 centimeters is considered as difficult mask ventilation and difficult laryngoscopy. The second view, thyrohyoid view, where I am traversing between the hyoid bone and the thyroid cartilage, it is a potential space to look into epiglottis. This is what the image we get, which looks like a small face or a frog's face appearance. If I want to interpret this, the eyes are nothing but the strap muscles which is meeting at the midline. The air mucosal interface, there is a bright line where air is passing across the epiglottis. The mouth part is what is epiglottis. The nose part is a pre-epiglottic space. Any fatty deposition or the thickness of this pre-epiglottic space more than 2.5 centimeter determines a difficult, again, laryngoscopy. There is also other way of looking at the difficult laryngoscopy. Just measure the distance from the skin to the epiglottis, which also acts as a modality to identify a difficult laryngoscopy and intubation. Coming to the next view, the thyroid view, when I place my transverse probe on the thyroid cartilage, the view is something like this. If you interpret this, the inverted, the V-shaped structure is a thyroid cartilage. If you carefully observe, there is one more inverted structure, a small V, which is an anterior commissure. The pyramidal structure on either side, this is the false vocal cord. The hyperintensive or the bright structures just below the false vocal cord are arytenoid. A very important take-home message at this juncture is if these 2 false vocal cords are not moving equally and simultaneously, this says there is some problem with the recurrent laryngeal nerve. If the blue colored, that is the arytenoids are not moving equally and simultaneously, that tells there is a problem with superior laryngeal nerve which supplies the tensors of the vocal cord. These 2 examinations help us in identifying whether there is some problem with the vocal cord or not. This is a space between a glottic opening, which also helps us to look through whether endotracheal tube is passing into the vocal cords or not. When we compare this with the endoscopic view, it exactly corresponds, whatever the image we took in the ultrasound exactly corresponds to endoscopic images of the vocal cord. This is a very interesting case. A 69-year male came to us, the female came to us with a history of stridor and hoarseness of voice. And we had already an endoscopic image in Hopkins to the lens. They always send us an endoscopic image before the patient is shifted to wheeled into the operating theater. When I put my ultrasound, this was the picture I got. It looks something like heart chambers. What I observed, there was no approximation of the vocal cord. The surprise was this. When I saw the endoscopic picture, you can see here, when they play a video, there are 2 pedunculated mass which was sitting in between the vocal cord. So the ultrasound really helps in a real-time image and helps us to know what is happening to the vocal cord. At the same level, it helps us to measure the air column difference in a cuff inflated and cuff deflated state. Thereby, it allows us to, this is a pediatric patient where when air column width in a cuff inflation is about 0.95 centimeters. When the cuff is deflated, it was 0.72 centimeters, which indicates there is a collapse. The air column has reduced with the cuff deflation so that this particular baby can go for post-operative distress. When I they place my probe in a mid-sagittal section, this is what the image we get. When I color this, the thyroid cartilage, the cricoid, which appears as a bump or the hump, are the largest pearl in that picture. You can see the largest pearl. The all other pearls are nothing but the tracheal image. If I reverse draw the anatomy, this is what it looks like. So it helps in identification of the cricothyroid membrane. Then the cricothyroid membrane should also be tested by placing a probe transversely. The TACA method, first identify the thyroid cartilage, come down, identify the air mucosal interface, which is nothing but the cricothyroid membrane, again go down to identify the cricoid cartilage, again come back. So this is a method to proper identification of the cricothyroid membrane. It also helps at this level, the width. If you measure the width at the cricoid cartilage, it helps us to determine the proper size of endotracheal tube, particularly in pediatrics. Suprasternal view, this is what the image we get. The darkest of this area is nothing but the tracheal lumen. If you see above the tracheal lumen, there is a hypoechoic structure, which is a cartilage, the tracheal ring. There is an air mucosal interface. Lateral to that, a ring-like structure is esophagus. Then if I color the thyroid, it looks like this, the carotids and internal jugular vein. If I reverse anatomy, this is what exactly, the striking feature is the esophagus always lies, with the use of ultrasound we learned, esophagus always lies lateral, left lateral, never behind the trachea, meaning, now the question arises, whether are we applying the cricoid pressure properly to prevent the regurgitation or the aspiration. So now the concept we are moving from the cricoid, some modification to cricoid pressure is required. I think we're moving towards a concept called, you see the dynamic picture there, the esophagus always lies lateral to it. You can see the peristaltic movement where the cursor was looking. So now we are moving to the concept of paratracheal pressure. Lots of evidence is still accumulating to whether we should switch from cricoid, some modification is required, or we may to switch to paratracheal pressure. This is an image where you can see some movements in the trachea that is actually endotracheal tube passing. We can never see endotracheal tube passing into the trachea. Some disturbances you'll get. In the same patient, when I removed the endotracheal tube and when I passed into the esophagus, you can see the double track appearance. The same patient, same condition, when I removed the tube and passed into esophagus, you will get a double track appearance. This is where we can, in this picture, we'll try to identify, I deliberately pushed my tube into the left side. This is what we'll get. That is the shimmering movements where the parietal and visceral pleura are rubbing each other in this picture. The same patient, I deliberately put into the left chest. You can see the movement in the left chest, but there is no movement in the right chest. What I did, when I put a M mode, this is where the motion mode appearance, this is what we get. This is nothing but the C beach appearance. So that means there is a normal lung sliding. And to the other side, there is no lung sliding barcode appearance. It also helps in diagnosing in a similar way the pneumothorax. So to take home, the light at the end of the tunnel helps in assessment and identifying difficult airway, predicting the size, the depth, and proper confirmation of the endotracheal tube. It helps in guiding the procedures in evaluation of larynx. I've got other 1 minute to demonstrate what exactly happened 2 days back when we started doing the airway workshop. I got this beautiful image of a volunteer. If you listen to my talk, you can identify what exactly is in this picture. This is the probe is kept at the transverse, in a transverse position on the thyroid. Can you see there is an unequal movement of the false vocal cords, and if you see the bright structure below, those are the arytenoids which are moving unequally. One is above, one is below. We were able to pick up, actually students picked up that there is some problem after learning. That was a reward that was given to us because when we showed them on other volunteers, they were able to pick up the vocal cord movements. This is one more picture, again taken on a volunteers day before yesterday. This is a normal vocal cord movement. You can see carefully the appearance of a cricoid cartilage. This is a tracheal cartilage. And when we go down, when we go up, this same cartilage becomes widens. Now it is becoming a cricoid from the tracheal rings. Now I am going down. So these are the images which we are able to get it in day before yesterday's workshop. Thank you for patient listening.
I think I must thank all the four speakers for a brilliant start to the day. I think the first two lectures were on pharmacology, not very easy to make pharmacology interesting to listen to. And I think the next two on the airway have been equally well presented and received. I'm sure there'll be a lot of questions. Please do come up with any doubts that you have. Because as I said, I think this is one of the best opening sessions I've seen at any conference. Thank you.